The evaluation of the thorax traditionally begins from the X-ray. It allows us to see how symmetrical the structures are and give us some clues about what we should point our attention in the future at. To read the X-ray of the thorax, we need to know how normal X-ray of the thorax looks like, right? It's always easier when you have a plan in front of your eyes. And this algorithm that usually is followed by a radiologist is here on your screen. We look first at the airways, then evaluate the bones, the shadows of the heart, the diaphragm, the domes on the right and on the left. They look at the pathological contents in the costodiaphragmatic recess. Then they move to the lungs and evaluate the fields of the lungs. They identify the bubbles of the stomach and hardware. And as you see, all these structures, they may be numerated from A to H for our convenience. Well, let's try to follow this algorithm, beginning from the airways. The trachea is a vertical line closer to the midline. It is filled with air that's whitish, kind of radiolucid, and appears darker on the X-rays. The carina and two main bronchi, they appear below the level T4. The X-ray of the thorax is useful when you need to evaluate the placement of the tracheal tube. Is it on place or not? Or then patient has some objects, the foreign objects in the bronchi. The other pathology which can change the normal picture of the trachea may be the growth, the tumor, or enlarged lymph nodes. If they are severely enlarged, and the trachea could be pushed from the midline to the right or to the left. Same is true about the archoaorta. By the way, if any aneurysm or dilation of the ascending or archoaorta present, that may cause deviation of the trachea from the midline. It seems like vertebral column is in front of the heart on this picture, and in fact it is true. It's a PA view. That means the picture was taken with patient touching the film with his front. It is a necessary condition to evaluate the size of the heart precisely. You clearly can see that clavicle articulates with the manubrium of Sterni at the level T45. This is our Lewis angle. And from here we can calculate the other T vertebrae, T3 and T2 above this level and T6, 7, 8 below this level. The X-ray is the most time-effective method which allows us to identify fracture and dislocation quickly. So we can look at the ribs here, the clavicle, scapular, and check how intact they are. The next mediastinal shadow to look at belongs to the heart and great vessels, and it's good to know that the upper part of the mediastinum is filled by ascending aorta on our right and aortic arch on our left, and the right border of the heart is made mostly by the right atrium. Here this part of the heart may be damaged in case of trauma, and the left border of the heart is made by the left atrium above and by the left ventricle below. The diaphragmatic surface of the heart, it lies almost completely on the diaphragm. From here the name. The size of the heart must be evaluated as well. The cardiothoracic ratio is used to do that. We divide the diameter of the heart to the diameter of the thoracic cavity. This ratio must be 0.4, 0.5, but never more. If we have more than 50%, we should think about the cardiomegaly, about the pericardial effusion, about the hypertrophy of the ventricles. It's a strong indication that something is wrong. And we are moving to letter D. The diaphragm is next to identify. The right and left domes of the diaphragm, they protrude upward, and normally the right one is a little bit higher than the left one. This is because of the big organ we have just under the right dome of the diaphragm, the liver pushes it a little bit up. Lateral to the dome of the diaphragm, between the diaphragm and the inner surface of the thoracic wall, you can see some angles, two recesses, the costo-diaphragmatic recesses. Normally they are kind of empty. We have a very thin film of pleural fluid here, and the lower parts of the lungs then slide down here in deep inspiration. So normally we have nothing in them. Sometimes we can see a level of fluid in this costo-diaphragmatic recess, and we call it effusion because we don't know what exactly this fluid is. We're gonna make the next step then and take some fluid out, aspirate it out, for the biochemical examination to make the precise diagnosis and to figure out is it a blood or a pus or lymph or just interstitial fluid. So normally the angles are empty. The fields of the lungs, they should not be absolutely transparent. We have some soft tissues, we have vessels, bronchial trees, which you see here on the right and on the left, running up and down from the roots of the lungs. Some shadows, this is the bronchial tree, and smooth lines all the way around. They belong to the vessels. Hypertransparency of the lung field is a sign of the lungs emphysema. It's not very good. That means we have too much air inside, which cannot find the way out. And have a look, we have no space between the lung itself and the thoracic wall. They are absolutely adjacent. We have the layers of pleura there, but it is invisible on the X-ray. Any contents like an air around is an indication of pathology. We also look how symmetrical the lungs are, sandwiching the mediastinum in between, in the center. Any deviation here will indicate the pathology. Under the left dome of the diaphragm, you can see some oval-shaped shadows. They are the air bubbles which we have inside of our stomach. And appearance of these bubbles on the X-ray is an absolutely normal sign. They are the normal structures. If patients have any devices in their bodies, such as nasogastric tubes or electrostimulators or EKG electrodes attached to the skin, of course, all these devices will appear on the X-ray too, and it will allow us to check are they installed correctly, are they on the right place or not. So this is one more point to focus our attention.